some people maybe ask, even the CR remission is very difficult to reach. Why we need to use this MRD technician to do this test and to design the disease population? I think for this question, we would ask another question: is that for Waldenström, there's a limited technical to detect the tumor, the real tumor burden. As we know, we use IgM as the indicator for this tumor burdens, but it's not a direct tumor burdens for factors. So we just want to use the direct tumor burdens technique to detect the tumor cells. So that's why we designed the flow cytometry to detect the monoclonal lymphocyte or polymerase cells in the bone marrow. That's maybe we present the tumor burdens change up before and after the treatment, and we can see that although using the traditional response criteria, the patient can't reach the CR, but the tumor burden in the bone marrow is very low. We can't detect with the flow cytometry. At this level, I think the patient PFS is very long. It's longer than the patient can detect. So from this aspect, I think the MRD technicians, the MRD strategy still has some usage, has some roles for the response evaluation. Of course, from another method maybe also can use to detect the MRD. The MRD to, for example, monitor the MRD-added using the ddPCR to monitor the MRD-added change is also another method, which we also use right now. I think in the future we will publish this kind of data to say that MRD maybe has a very important role for the response evaluation of Waldenström patients. Thank you.